Good afternoon and welcome to today's Center for Healthcare Strategies webinar that is made possible by Kaiser Permanente Community Benefit on combating childhood obesity through Medicaid public health partnerships, lessons from the field. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 2 moderated question and answer sessions during today's presentation. You may submit a question online by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on CHCS.org website. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you will take a moment to do this. I will now turn the webinar over to my colleague, Alex Mall, Program Officer at the Center for Healthcare Strategies.
Thank you, Rosa, and hello, everyone. My name is Alex Mall, and I'm delighted to welcome you to today's webinar made possible through support from Kaiser Permanente Community Benefit. I'm going to start us off with a brief overview of the Center for Healthcare Strategies. I'll then give a bit of background on our Innovations in Childhood Obesity initiative, and then we'll go right into today's panel. So for those of you that aren't familiar with us, CHCS is a national nonprofit policy center dedicated to improving the health of low-income Americans. We work with state and federal agencies, health plans, providers, and consumer groups to create programs that better serve beneficiaries of publicly financed health care, particularly those with complex, high-cost needs. So we know that childhood obesity is a serious health concern in this country. Nearly 1 in 6 children in the U.S. is obese, representing a very serious public health problem and contributing to increased risk for many chronic conditions later in life. And we also know that it's an issue that often affects low-income families facing multiple social challenges such as trauma, early adversity, and poverty. So through a scan that we did a few years ago, we found that prior efforts to address the issue were largely siloed, with few activities involving meaningful collaboration between Medicaid and public health, but that bringing together these sectors, bringing together public health and Medicaid leaders, provides an opportunity to really leverage their respective strengths and advance interventions aimed at this issue. So in collaborating, Medicaid agencies can leverage the strong health promotion infrastructure of public health agencies to really reach low-income populations. And then, in turn, public health leaders receive insights into the needs of Medicaid beneficiaries and can encourage alignment across Medicaid payment systems and public health objectives. So with support from Kaiser Permanente Community Benefit, CHCS has worked to leverage this untapped opportunity and start our initiative, Innovations in Childhood Obesity, that began in 2015. It's designed to foster cross-agency collaboration between Medicaid and public health organizations to really develop and test innovative approaches for reducing obesity among low-income children. We have been working with Medicaid and public health leaders in 5 states. We are grateful to have been working with some really wonderful folks in Arizona, Maryland, Oklahoma, Oregon, and Texas. And we received subject matter expertise from our advisory panelists, including Anil Kapgoda, Shika Anand, Kerry Duima, Ayuma Anelli, Sandy Hisink, and Lowell Solomon. Really wonderful folks there, so thank you. We've also partnered with our evaluators, Carolyn Berry and Margaret Paul from the NYU School of Medicine, and they helped us to test these interventions that have been carried out by the 5 states. Today's panel discussion will be with Medicaid and public health leaders from all 5 of our Innovations in Childhood Obesity states. Our panelists will share lessons from their efforts, and we're really excited for them to talk more about some of the strategies that they've used for recruiting and engaging cross-sector teams, designing incentive metrics, and implementing strategies to address upstream causes of childhood obesity. We'll start with session 1, where we'll ask the panelists to highlight some of the strategies that they've used for fostering cross-sector collaboration. In session 2, we will cover progress that our 5 teams made towards preventing childhood obesity in their states and really hear about some exciting new steps that they're taking to further the field. Both of our panel sessions will be followed by a moderated Q&A session, and once we get a little bit closer to the Q&A sessions, I'll provide some more detail about how to submit questions. So we are so delighted to feature representatives from all of our ICO teams on today's panel. We have Nancy Goff with the Oregon Health Authority representing our Oregon team. Representing our Texas team, we have Erica Juarez from the City of Laredo Health Department in Laredo, Texas. From Oklahoma, Jenny Kalbach with the Oklahoma State Department of Health, and Miguel Soto from Oklahoma Medicaid, the Oklahoma Healthcare Authority. From Maryland, we have Glenn Schneider with the Horizon Foundation, which is a philanthropy located in Howard County, Maryland, dedicated to improving health and wellness. And from Arizona, we have Eric Tack with the Arizona Healthcare Cost Containment System, which is Arizona's Medicaid agency. So we are going to get started with our first panel topic, which is highlights from the collaborative model. Just as a reminder, to send us a question at any time during the panel, please click the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. All right, so I'm excited to get into the panel. I'm going to turn now to our first panelist, Glenn Schneider from the Horizon Foundation in Maryland. Glenn led a really diverse group of partners to address childhood obesity where there are high rates of poverty and chronic disease in areas of Baltimore City and Howard County. And the large team was pretty well represented by state Medicaid and public health, city and county health departments, Medicaid managed care organizations, and the Maryland chapter of the American Academy of Pediatrics. And their intervention focused on several things. It was a very multifaceted effort around creating new data systems to measure obesity prevalence in children, transforming high-volume Medicaid practices to better prevent and diagnose and treat obesity. They also looked at how to assess how to better treat severe obesity through specialty treatment centers, and then also delivering nutritional counseling in community settings. So just a little bit of background about their work. Glenn, we'd love to hear from you. Can you tell us a bit more about how you recruited and engaged such a large, diverse team? And could you please share a few strategies that you used to reconcile the different missions and goals of all of your partners?
Alex, I'd love to. Hello, everybody. So excited to be on the phone with all of you, and thanks so much for listening. Alex, I think you have really given us an opportunity to talk about things here in Maryland that otherwise we wouldn't really be talking about. And let me kind of break this into 5 key lessons that I think that we take from our experience working with CHCS over the last number of years, a couple years anyway, year and a half. So number 1 is that I think that we started off with having relationships with each other from working on various projects together. So all of the groups that we're talking about, each of us had different relationships with each other, and we worked with each other in our normal silos. I think that the first lesson I think that's really important for all of us is that you gave us a reason to come together. So rarely is it that you have Medicaid and public health working together on projects that are really important like this. And this gave us an excuse, if you will, to call everyone up and say, hey, look, we have this learning collaborative going on. Let's come together and really discuss how we can improve the treatment of obesity in Medicaid. And so lesson number 1 is even if you don't have a collaborative like the one that we had with CHCS, you can do your own. You can still give yourselves a reason to get together, and that's an extremely important part of the work that we did. Simply giving yourself an excuse to get together as public health and Medicaid to solve problems. So that's number 1. Number two, and that's true, by the way, regardless of whether you call it a task force, a commission, a collaborative, or whatever you might call it, by giving yourself a reason to get together, it really helps to bring folks together. Secondly, I think that the second most important thing we did was consider the data. So we took a long look at what we knew about this issue in Medicaid, and we found out that we didn't have a whole lot of data available. So we tried to have to think about how exactly we could collect the data that we needed so that we could be evidence-based in the work that we did. And so we spent a good long time in thinking about how could we either collect data within Medicaid that would tell us the prevalence of obesity, for example, in Medicaid enrollees, or if we don't have that, what would be good proxies? So we considered the data, and we tried to figure out at first what is the data that we needed to drive us ahead forward along in this process. Lesson number three was simply hold yourself accountable by having regular meetings. So the collaborative function and the idea was that you go ahead, you have a meeting, you discuss, you have action steps, and you do. And I think having at least one person who is designated as the administrator, if you will, for a person who can keep the trains running and being able to make sure that people are following through on tasks is really important. But we all held ourselves accountable to that sort of work. We knew that this was important work. We wanted to make sure that we followed through with our action steps, and people complied and made sure that that happened because we had regular meetings. Lesson number four is understand everyone's different perspectives. We thought we would be stronger by bringing together a lot of different perspectives, everyone from providers to local health departments to Medicaid to philanthropy, and in having those different perspectives, being able to understand why something that I think in public health is really important, Medicaid might find expensive or prohibitive because of that expense. And so that was a very important thing of being able to explore each other's perspective on the issues that we would bring up. And then finally, I think it's about thinking creatively about problem solving. So we try to think throughout the course of this of what is it that we want to focus on, and then what's the best way of making that happen. And throughout the course of this whole period of time, we bobbed and weaved to try to figure out how we could solve problems creatively together. And I think we were successful in some. We are still trying on others. And we'll talk a little bit more about some of the other ones later on in the program. So those are my 5 lessons. Again, in review, create an excuse for yourselves to get together. Consider the data and use it to drive your work. Hold yourselves accountable with regular meetings and having an administrator to help push you forward. Understand everyone's different perspectives and work with those perspectives. And then lastly, think creatively about problem solving. And there you have it.
Glenn, thank you so much. Great strategies, love the lessons. So just as a reminder for everybody to submit questions, just chat them to us using the drop-down menu. So we're going to turn now to our next panelist, Erica Juarez with the City of Laredo Health Department in Laredo, Texas. Erica and her team at the City of Laredo Health Department partnered with 2 Medicaid managed care organizations and 2 Laredo school districts around reducing the risk of obesity and diabetes. And just to give you some background, Laredo is a rural, low-income area along the U.S.-Mexico border. It has high rates of poverty and chronic disease, and more than 30% of children between 5 and 11 years of age are overweight, and rates of obesity are on the rise. So to address the issue, the Texas team collaborated to implement Vienna Star, which is an evidence-based, school-based health program that addresses childhood obesity and diabetes risk factors. So Erica, we'd love to hear from you about how you developed your relationships with your partners at the Medicaid managed care organizations and what their roles were in the intervention. Thanks.
Well, thank you, Alex. Again, thank you for the invitation, not only to participate in this project, but to be in this panel today. There were a lot of lessons learned and a lot of opportunities created from the inception of this project. As Alex mentioned as well, it was pretty much a couple of years of us working in this, and like she mentioned as well, our community is a community that is rural. There's a lot of low-income areas in which we definitely see the problem of obesity. So as part of this project, it created an opportunity for us as a public health department to revisit this problem in a different light, because we know it's highly prevalent. So pretty much with the long history that we have of partnerships with different organizations in our community, we share the same goals. You know, we all want our community to be healthy and to be, you know, conscious of their health. So along those lines, we were able to, you know, see this opportunity to work, you know, deeply with these particular stakeholders. We wanted to make sure that we engaged the right ones, you know. So we succeeded by collaborating with the 2 major school districts in Laredo. They have a large population of Medicaid recipients. So through this collaboration, it took some time, but when we were able to relay the message to the superintendents as to why it was so important to implement this project, they were completely on board, and they included the right persons, you know, from their respective school districts. So that way, we have them on our side, you know, the school districts. So we have the nutrition services director, the health services directors, the cafeteria staff, and then, you know, after a while, we were able to include school administrators, teachers, PE coaches, etc. So we work in solidify a relationship with the schools, because we collaborate in many, many ways, you know, throughout time. But for this project, we wanted to make sure that we were going to be able to fully implement the program. So at the same time, we needed funding. So through that side, we established that relationship with 2 managed care organizations that were really good. But at the beginning of the project, they were going through some changes. So that added some difficulty to the project, but nonetheless, we were able to, you know, solidify that relationship as well once we were able to secure who was going to be our contact person, and they were absolutely great, you know, in participating in this project. So altogether, we met regularly. We developed these partnerships so we could have a work plan to achieve our multiple goals, including implementing this curriculum, because it's an evidence-based curriculum that we know has a history in that area of Texas. So the target was to work with 2 particular schools. So in this particular case, what we did is that one of the MCOs, Superior Health Plan, was absolutely great about participating in this project, because they went the extra mile. In this particular case, this contact person, Martha Saldivar, she was the rock of this project, because even though she had just started to work with them, she made sure to secure all of the resources so we were able to provide a curriculum. She was always present for our meetings with, you know, the administrators, with the teachers, with the coaches, and at the same time, she always she was always active, you know, in providing multiple types of incentives that were related to physical activity, nutrition education, and at the same time, she scheduled presentations with the parents, Zumba classes for the kids, again, providing them incentives. So this relationship was not only about implementing a curriculum that provided us with data about, you know, the status of these kids, their nutrition knowledge, you know, biometric measurements. At the same time, this good relationship that we established with the MCO or with both MCOs was something that is going to endure through time, because even though the project has ended, that relationship is ongoing. So they keep scheduling events, they keep attending presentations. They're very active with these schools, and one of these particular schools is in a very secluded area. Most people walk to school or back to school. They're very low income, and about 94% of those school kids are Medicaid recipients. So in that particular area, she was able to do a lot of work and engage the parents in, you know, getting more active and listening to their kids because they were learning all of these great things, but we wanted to make sure that that message was relayed to the parents as well. So the education involved both the kids and the parents, but without, you know, the help and the support from the MCO, it would not have been possible. So throughout the whole project, there were some hiccups as expected and, again, lessons learned, but we know now that through these partnerships, we can definitely achieve a lot of good things for these kids because we definitely need it. We're talking about a population of kids that probably at the age of 6 already had gallbladder surgery. So it was extremely important for us to make sure that they didn't only receive the education and all of those incentives, but at the same time, it was just going to be the start of an ongoing relationship with our kids and the MCOs, and us as a public health department, for sure.
Great. Many thanks, Erica. We are going to move now to our next panelist, just so we can stay on time. Jenny Kalbach with the Oklahoma Public Health and Miguel Soto with Oklahoma Medicaid. To give you some background on their work, Jenny and Miguel were part of a cross-sector work group that came together around reducing childhood obesity in Comanche County, which has the 3rd highest rate of obese Medicaid beneficiaries in the state. And their work group included members from the Oklahoma State Department of Health, the Oklahoma Healthcare Authority, the University of Oklahoma Healthy Futures Clinic, the Comanche County Health Department, and federally qualified health centers in Comanche County. So they had a great, diverse team. They were all working towards increasing the use of nutritional counseling services among children covered by Medicaid in Comanche County. So Jenny and Miguel, can you tell us a little bit about what prompted the Medicaid and public health agencies in Oklahoma to come together, and what did the leadership see as the value proposition? Did you all build on any existing efforts for this work?
All right, well, thank you, Alex, and thank you, everybody on the call. We appreciate this opportunity to be here with you guys today. So in 2014, leadership from both the Oklahoma State Department of Health and the Oklahoma Healthcare Authority initiated discussions to try to implement interagency collaborations on mutually reinforcing strategies and the coordination of those tactics on various health issues affecting the shared population we thought would benefit both agencies and present an opportunity to reduce potentially duplicate, overlapping, and fragmented efforts. So work group topics at that time consisted of health priority areas identified in the Oklahoma Health Improvement Plan, and that included tobacco, diabetes, hypertension, prescription drug abuse, and immunizations. And then during the second phase of the collaborative work in 2015, childhood obesity was added as a priority topic to align with also the collaboration opportunity through CHCS. And so the work group members were selected by the Joint Strategic Plan Steering Committee and were chosen for their knowledge, skills, and abilities to contribute to the outcomes of the effort. The work group members were granted also the authority and autonomy to select the QI project initiatives and measures, and suggestions for the quality improvement focus were taken from all work group members. And they were evaluated based on available data for both baseline and future measurement, priority based on sooner care membership and need, so obesity diagnosis, and also resource allocation and availability from both agencies for personnel to participate.
Hi everyone, this is Jennifer. I'm going to talk a little bit more about our team. So from the beginning, the group had great enthusiasm and participation in the program from both the lead agencies, Medicaid and Public Health, and the community partners, which Alex mentioned. And that mostly included our federally qualified health center, which provided the referrals for nutritional counseling, and then later on a local YMCA, which also provided physical activity opportunities for the children and the families participating in the project. Our group held monthly meetings that provided updates, addressed challenges together, and then worked to develop solutions. One of the biggest challenges we had was providing the information and interpretation of the Medicaid benefit coverage for the nutritional counseling services to ensure that providers first knew that the benefit existed for their patients,
Second, knew how they could utilize it and who needed to make the referral. And then finally, how they could utilize their county health department to provide the services because they were staffed with registered dietitians. Our biggest asset in this project was our registered dietitian in Comanche County, where we targeted for having the third highest rate of childhood obesity based on Medicaid claims. From the onset of our project, both she and the county administrator were 100% on board and enthusiastic about the project. Her knowledge, skills, and passion were really the driving force behind getting the referral numbers up and increasing utilization of the nutritional counseling benefit. Most projects are successful because they're led by a passionate champion in the community, and I'm sure all of you have experienced that, and we were very fortunate to have found that community champion in our dietitian. And it's not always easy to find this person, but we're definitely lucky that we did. And from our agency leadership from the outset, they were both very involved in the project and very willing to provide staff time and effort, as well as letting us choose the project area and then providing guidance throughout.
Okay, thank you so much, Jenny and Miguel, and it's really nice to hear the perspectives from both of you, giving a perspective from each agency, so thank you. We're now going to hold a brief moderated Q&A session with all of our panelists to hear more about their work, and as a reminder, all of the lines are muted, so to send a question, please click the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. So we have a question for Erica. Erica, can you tell us the names of the managed care organizations that you partnered with?
Absolutely. It was Molina Healthcare and Superior Health Plan.
Great, thank you. And then we also had a question for Erica. Can you explain the BNSR curriculum a little bit more? Can you just describe the major facets of the curriculum?
Sure. The BNSR curriculum, like I said, is an evidence-based curriculum that targets children in different ages, you know, from kindergarten to elementary school, and it includes different areas of education that not only involve the kids, but it has lessons for the cafeteria staff, it has lessons for the physical education coaches, it has lessons for the teachers, the parents, and the children, so they all learn at the same time, depending on the grade that's targeted. So the curriculum is the amount of lessons, but it can vary from 10 to 13 lessons, depending on the grade that's targeted. It's a very comprehensive bilingual curriculum that we were able to observe that pretty much the majority of the children improve their nutrition knowledge. Like I said, it targets the cafeteria staff as well, so it was great to see how when these kids were going to, you know, get their lunches, they were more inclined to choose something healthy because now the cafeteria staff encourages them as well. So it's a great curriculum that you know, targets different sectors in the school.
Great, thank you, Erica. Jenny and Miguel, we have a question for you. Can you tell us a little bit more about how you educated providers around the nutritional counseling benefit?
Yeah, absolutely. So we did a couple things, and the first was having a face-to-face meeting with the specific federally qualified health centers that we started the project to do the referrals with, and that was going and meeting with them and explaining how the referral process worked and explaining the coverage benefit to them. The second way was we had a one-page information sheet, which was developed by the Healthcare Authority, to explain not only the benefit for children, but also the benefit that was how it was covered for adults and then also for pregnant women, so providers had all the information for all their potential patients. And then we also included some of that information in the trainings that are done for providers by the Healthcare Authority.
Great, thank you. And one other question for you. What advice would you give to other agencies considering collaborative efforts like the one that you all have undertaken?
So I would say one of the biggest benefits for us was that our state had targeted areas for health improvement. So Miguel had mentioned that our collaborative came out of that. And we also had groups that were focusing on projects related to tobacco, immunizations, and chronic disease. So I would recommend, if people want to do collaboration, if you have a state plan like that, definitely look at the high-level priorities for health improvement for the state, and then also see where things can align. So for public health, typically your services are for everyone, and Medicaid obviously has a very specific population that they cover and that they serve. So looking for cross-cutting health issues, and then also where you can overlap in the population that you serve, so both agencies benefit.
Great, thanks so much, Jenny. That's really helpful. We have a couple questions for Glenn, but we're going to save them to the end because, Glenn, you're going to be speaking again on our next panel session. So we're going to go on to our panel session 2, which is hearing about some of the exciting advancements made by our ICO states. So we are going to start with Nancy Goff with the Oregon team, and a little bit of background about their work. The Oregon Medicaid and public health entities within the Oregon Health Authority have been partnering to reduce childhood obesity across the state by promoting evidence-based strategies for obesity prevention and treatment, and also helping to facilitate the adoption of a childhood obesity incentive metric in Oregon. We are really excited about this, and we feel like it can really move the field forward in terms of various incentive metrics for childhood obesity. So Nancy, we'd love to hear more detail from you about the incentive metric and next steps for coordinated care organizations in Oregon.
Great. Thank you, Alex, and thanks for having us on the call today and participating in this project. Today I wanted to share a little bit of our story about our current work on selection and implementation of the Childhood Obesity Incentive Metric in Oregon. But first I probably need to explain a little bit about how our system is structured so you can understand the significance of this work. So in Oregon, Medicaid is delivered through 16 coordinated care organizations, or CCOs, I'll refer to them like that divide the Medicaid population based on the geography of the state. And CCOs are similar to ACOs or MCOs in other states and are essentially health plans or health payers. CCOs are accountable to quality health metrics that show how well they're meeting the triple aim of better health and better care at lower costs. And they receive funding in the form of global budgets from the Oregon Health Authority, which is the state agency that includes both Medicaid and public health. And then they also receive additional payments for meeting benchmarks or improvement targets on 18 quality metrics. And the metrics cover a diverse range of health topics like depression, adolescent well care, diabetes, dental sealants, and others. And they're selected annually by legislatively mandated committees that are staffed by the Oregon Health Authority. And for many years, the Health Promotion and Chronic Disease section of the Public Health Division, which is where I work at OHA, has been working to raise awareness about the obesity crisis and some evidence-based policy systems and environmental change strategies that could help address the crisis and improve outcomes. And the outreach that we've been doing has mostly been in the form of meetings between various partners and presentations to key decision makers across OHA, especially the Medicaid and public health departments within the agency. And this collaboration has all been built on a long history of successes in topics like tobacco, maternal and child health, and immunizations. So, in a parallel story, in 2016, the Health Evidence Review Commission, or the HERC, which is another state-level legislatively mandated committee that governs Medicaid coverage decisions, started to work on what they call a multi-sector intervention report for obesity. And the HERC created, and they do create multi-sector reports to be used as guidance documents for the CCOs. The reports are typically created by a scientific advisory committee that reviews the evidence-based strategies around any single health topic area and compiles a list of recommended strategies that have been shown to improve health outcomes. And the multi-sector reports are often aligned with what we'd see, for example, in the CDC's Community Guide or the U.S. Preventive Service Task Force guidance. And as many of us know, working in public health, many of the most effective and impactful strategies for improving health outcomes are indeed strategies implemented outside of the clinical setting. So for this obesity multi-sector report that was published in 2016, it included strategies like school and child care-based interventions to reduce BMI, school nutrition policies, increases in access to active transportation options, workplace physical activity programs, and sugar-sweetened beverage taxes. So while the multi-sector report doesn't direct CCOs to invest in these strategies or even permit them to spend their medical dollars on them, it gives them a menu of options to invest in that will allow them to improve obesity rates at the population level. So public health was involved with this cross-agency work group that helped create this report, and after it was published, we shared the results with the committees that choose metrics that I was describing earlier. And the committees acknowledged the increasing interest in obesity, particularly childhood obesity, in Oregon's healthcare system. And just this past summer, 2017, voted in a nationally standardized metric, which is weight assessment and counseling in children and adolescents, as an incentive metric for CCOs in 2018. So they'll begin reporting on this measure in 2018 and will receive incentive payments for meeting benchmark or improvement targets. So why is this important or significant? Well, with the implementation of an incentive metric, CCOs will now be held accountable to making improvements in the process of documenting BMI and discussing weight with children. However, we know from the research that physician discussions about food or exercise in the primary care visit will do little to reduce obesity at the population level if it's not paired with interventions that change the context in which people live and make physical activity and healthy eating easier and more accessible for everyone. So luckily, we have the multi-sector report that I also described in Oregon to help guide some of the policy, systems, and environmental strategies that will complement the clinical strategies and together help move the needle on obesity. So we're hopeful about continuing this cross-agency collaboration and the work we've started, and we'll continue to work with the committees that choose metrics to ensure that our childhood obesity metric gets stronger over time. We found that the nationally standardized metrics for obesity that are currently available are not measuring strategies that have been shown to be effective. For example, there's not evidence that weight assessment in primary care will improve obesity rates. However, that's one of the few national quality measures that's currently available. So there's interest in Oregon in the future in developing a new bundled metric that will be reflective of what works. And we hope this metric will include things like BMI tracking, referral to intensive behavioral interventions, closing the loop on referral to interventions so that providers know when treatment was received, and finally, investments in policy systems and environmental change interventions that I mentioned earlier. So in the next year, we'll have more information about that progress on the new metric, and I'm happy to talk with anyone from other states that are interested in learning more about our approach. Thank you.
Thank you so much, Nancy. We'll now turn to Eric Tack with Arizona Medicaid and some background about the Arizona team's work. So the state has been prioritizing initiatives related to childhood obesity prevention, including assessing strategies for improving service delivery models for the Medicaid population. And Arizona Medicaid partnered with Medicaid managed care organizations and Mountain Park Health Center, which is a federally qualified health center, to conduct a needs assessment of services to address childhood obesity in Maricopa County, which encompasses Phoenix and surrounding communities. And this work really led to some exciting new steps, which I am delighted to have Eric talk more about. So, Eric, can you give us a couple of highlights from the needs assessment that you all did and describe some of the new efforts and collaborations in Arizona to address childhood obesity?
Thank you, Alex, and Arizona wants to thank you for allowing us to participate in the collaborative. To dovetail off what Glenn said earlier during the presentation, I'm going to take up points 1 and 2. 1, you need to collaborate with your community partners, and 2, you need to look at the data to see what initiatives you might be able to then pursue. So as a background, the objective of our study was to conduct a needs assessment of the current service provision model for Medicaid and Kids Care members of Access. 1,195 Medicaid members between the ages of 2 and 5 who were identified with BMIs greater than 85% for age were identified and who were being seen at Mountain Park. 210 members, or 18% of the cohort, received at least one counseling service. So because of this result, a review of the member identification and referral strategies was needed to be explored throughout the healthcare delivery system of the Medicaid program. I think in the materials that Alex is sharing with you, you're going to have a slide in terms of what does obesity in the childhood population look like in Arizona, so I'm not going to go through that. But what we identified initially for the study were several key areas and challenges. 1 was lack of service delivery and system integration. 2 was a lack of coordination of care and services. 3 was a lack of education and support to family members. And 4 was identifying the need to develop policy language and/or contract requirements that include childhood obesity program components without a fiscal impact to the program. So it was a claim-based data study, and we looked at children between July of 2015 and December of 2016. 9 managed care organizations who are contracted with the agency here participated and had members who were being seen at the Mountain Park facility. 111 of those members received only one service, whereas 99 of the members received more than one service. And I think we're also sharing with you the CPT codes. And the most frequent of those were a nutrition consult and or a visit with either a psychologist or a social worker. So we're sharing those codes with you so that you understand what those visits actually looked like. We didn't see any increase in BMI during the study period. There was also a lack of wraparound and supportive services. There was also no demographic information that we could really hang our hat on to help strategize and develop some initiatives. So the takeaway here was really 5 points. So looking at some advances and initiatives that we as an agency could provide. 1 managed care plan currently is addressing through an internal corrective action plan an ability to increase the identification of eligible members to either increase a social service or a dietary service intervention. 2, we're encouraging the obesity subcommittee from the local chapter of the American Academy of Pediatrics to update their current obesity toolkit. 3, we have 2 new pediatric weight performance measures that are being added to a contract deliverable for all the health plans to report on, and this will be starting in the first quarter of 2018, and these will align with the requirements in the new 4th edition of Bright Futures. We also were receiving a 5-year targeted investment grant through CMS, and we're finalizing those metrics right now, and we're seeing if one of the BMI metrics might be able to be incorporated into the outpatient or ambulatory part of that program. And lastly, we're considering to develop a value-based strategy with financial incentives for incorporating the AAP tools and other tools into a clinical practice. And so that was incorporated into our new RFP that went out in November. So other than that, and I'm not going to review the other slides that we're sharing with you, with the group, but if you have other questions, I'll be happy to talk to anybody from the other states and how we are addressing and trying to develop some interesting initiatives to address the issue here in Arizona.
Eric, thank you so much. So we're going to turn now to Glenn to round us out as our last panelist. We're really interested in hearing more about the work that, Glenn, that you did with your team in Maryland and how it led to some really exciting new efforts exploring upstream pathways for Medicaid to cover nutritional counseling by dietitians in the community. So Glenn, I'd love to hear more.
Hey, Alex, thank you so much. And again, thanks to everybody. You know, as we dug into the work that we were doing on the collaborative, at some point we too looked at our data with regards to billing data in Medicaid to understand whether our providers were actually billing for what we would call, quote unquote, advanced treatment of obesity, which might include nutritional assessment and things like that. And what we found is that our providers weren't doing that enough. We were thinking that that was pretty low given what we found as the prevalence of likely obesity in our members. And so we started diving into why that might be the case. We talked to providers, we talked to the MCOs, we tried to figure this out, and what we found is that A, providers didn't know who that they could refer to. They don't know necessarily who registered dietitians are. And so typically if they wanted to do a nutritional assessment and provide sort of counseling, they would send their patients to the hospital. And oftentimes, as you can well imagine, if I am sent to a general hospital to try to figure out where to go, I may or may not have any idea where to go, and I probably may or may not show up. And so we started thinking about all of these things of, you know, what are the barriers to, A, providers getting referrals for their patients to the right place, trying to get our patients to actually show up at the appointments that they were scheduled for, what could you bill for, and things like that. And all of a sudden, CHCS provided us a phone call from Debbie Chang from Nemours. And this conversation was about what can we do to move services that are traditionally offered in providers' offices. How can we move them into the community setting? Let's move upstream a bit and think about how we can better deliver services to our patients. And as we thought about this, we said, you know, isn't there a way for us to creatively tackle this problem? Given the work that we have done in our community here working with Head Start, it made us think of, you know, in places where we have had providers present to give nutritional information or to deliver a curriculum like Eat, Play, Grow, are there opportunities for us to embed a dietitian perhaps in a Head Start setting so that parents and students view that registered dietitian as a teacher and develop a trusting relationship with them so that when they are saying, let's sit down and talk about nutrition, that they are seen as a person that is very close to them already and close to their children so that there is some progress there. And so we started to have those conversations, and it turns out that we were lucky enough to enter into another collaborative with Nemours and Academy Health and 2 other states to try to figure out if there's a way for us to move more upstream. What are the barriers to getting a dietitian embedded into a Head Start, for example, where we know that a number of those children are likely Medicaid enrollees? And so for the past number of months, we've been in that part of this sort of exploratory phase and trying to figure out, A, what can we do to help providers do a better job of referring? How can we help the MCOs to do a better job of allowing these sort of things to occur? And how do we think about billing and embedding so that this could work in the future? So we're still along the path on this, trying to figure this all out. But I think none of this would have happened, perhaps, if it weren't for the collaborative that we started in the very beginning. Those relationships that we developed with our Medicaid agency, the ability to say, we made some progress on some of these other things, can we make progress on this? The willingness of our Medicaid agency to step up and say, we understand this is a problem, is there a creative solution to it? All happened because we've been meeting as public health and Medicaid agencies together to tackle these problems that are very difficult and oftentimes not addressed adequately without this collaboration. So I'm excited that we're still working on this, and I'm hoping for any of my Maryland team that are on the call today that we continue to meet, as we hoped and hopefully plan on continuing to meet, to solve these problems that we've found are very important in our community.
Glenn, thank you so much. We're looking forward to hearing what happens and what's next for you all. So we're going to now hold a brief moderated Q&A session with these speakers to hear more about their work. And just as a reminder, I know we've said it all along, but we want to make sure that those who have questions can send them in. So to send a question, click the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. So we're getting a number of questions. We have one for Eric. So Eric, we heard that there have been some new cross-agency efforts going on in a state in Arizona in the past few months. Wondering if you can let us know a little bit more detail about these efforts and what the next steps entail.
Alex, we partner and do a lot of collaboration with the Arizona Department of Health Services. And as part of their statewide initiative, they have a semi-annual AZ-HIP Summit, which just met 3 weeks ago. There are multiple subcommittees within that summit, and one of them is childhood obesity. Each of the subcommittees have an action plan, and so the obesity subcommittee action plan actually has 4 evidence-based high-impact strategies. Number 3 is what actually dovetails with the agency here in terms of ensuring coverage of and access to and incentives for routine obesity prevention, screening, diagnosis, intervention. So the tactic here is to promote education for current and future providers, and that the action items include collaboration with the Arizona Academy of Pediatrics, with the Arizona Department of Health Services, with actually 2 of our contracted managed care organizations, and with the Access Agency itself. So I think in terms of looking at that, and I'm just picking out the obesity part of that because we've got a maternal child health group, we've got an immunization group, and other things like that, we're trying to de-silo the agencies and work collaboratively with the other community stakeholders.
Great, thanks, Eric. We have a question for Nancy. Nancy, do you have any suggestions in terms of how to make this happen, so how to adopt incentive metrics for other listeners that are thinking about how they can make this sort of thing happen in their state?
Yeah, I mean, first I want to say I'm not taking credit in any way for one person or even one department in developing statewide incentive metrics. It was definitely a collaborative effort of multiple departments within the Oregon Health Authority, and also under the broader scope of health systems transformation. So we've had some really strong leadership in our state for decades to help transform the healthcare system, and the creation of CCOs a couple of years ago really helped to kind of put this into practice. And one of the foundational elements of CCOs is having incentive metrics, and now we're starting to see that align with other initiatives around the country, things like MACRA, and we see other incentive payment systems kind of emerging. But I would say that this has been a very, very long-term thing, that this is something that's growing and it's changing all the time. The structure of how our incentive metrics are chosen is also changing. And really what we're doing from public health end is trying to make sure that we have good relationships with the Medicaid side of the agency, that we understand each other's work, and that we try to work collaboratively in an ongoing way with all of the various topic areas where there's overlap between the two agencies.
Thanks, Nancy. One more question. Excuse me. Do you have access to referral interventions for the management and treatment of childhood obesity in Oregon? Did you know of any or that you all have worked with?
Yeah, so I responded to a question on the chat box. Really what we're trying to focus on is the most promising strategy that we have right now is building the diabetes prevention program as a program to refer to for obesity. We have a statewide network of DPP providers that's growing, so we have the infrastructure that's growing in health care systems and also at the community level in community-based organizations. And as we start to grow that network, we're hoping that we can start to link healthcare systems and build those community clinical linkages so that we can get the program being used. We do feel that diabetes prevention program does meet the requirements for intensive behavioral intervention in a way that would be effective at treating obesity. So we feel like that's the most promising thing right now, and another part of our work is to help grow that program statewide. Great,
thank you, Nancy. So Eric, we have a question about how do we get the needs assessment and results. So I just want to let everybody on the call know we shared the results within a profile that we wrote talking about or describing Eric's team's work that's located on our website, and I'll talk a little bit more about how to find that at the end of the call. And Eric had referred to some slides when he was talking, and we've also attached those alongside the profile. So we'll send out the link and make sure that everybody has access to that. And so I think we're just at the end of time for our Q&A. So what we're going to do is any questions that we're not able to answer, we haven't been able to connect you with in terms of the chat going on during the call, we'll follow up with everybody afterwards. We're going to go to describing some of our new resources. We're really excited about these. We have released a set of profiles and a summary brief, as you can see on the slide, and these are really around sharing key insights from the work that you've heard about on the call today. And all of these materials can be found on our website at www.chcs.org. We'll also share an online resource center. You can see that as the third bullet on the slide. That will be shared in mid-December. We're really looking forward to that, and that's going to provide practical tools to spur Medicaid public health collaboration for reducing childhood obesity in low-income populations. So we'll be sharing some tools that you heard about on today's call. And then I wanted to just say how excited we are about this work, because this work has really prompted other CHCS cross-sector collaborative initiatives, such as some work that we've been doing with the CDC around their 618 project, which supports public health and Medicaid partnerships to implement evidence-based interventions addressing common higher-cost health conditions. And also our State Oral Health Leadership Institute, which offers an opportunity for state Medicaid dental program directors and state oral health program directors to come together. So we're looking forward to having the chance to pursue additional cross-sector efforts and hope that you find these resources during today's call helpful, as well as others from our cross-sector work. And want to give a big thank you to everybody on the call for your great questions, and many thanks to our panelists for joining us today and for their terrific work discussing their interventions. Thank you again to Kaiser Permanente Community Benefit for funding for this project. And we hope everybody has a great holiday season. Take care. Thank you.